Very important topic, complications of pterygium surgery and its management by Professor Arun Kumar Jain. Sir, Professor is head of the department of Unit 3 Cornea, Cataract and Refractive Surgery at PGH Chandigarh. He has done his fellowship from University of Madison, USA. Is a visiting fellow, Moran Eye Center, Salt Lake City, USA, and he has more than 100 publications in peer-reviewed journals. He is a reviewer for ophthalmology, American Journal of Ophthalmology, and cornea, JCRS, IJO, ophthalmic surgery, lasers and imaging, MIAJO, APJO, SJO, and many more. It's over to you, sir.
Can you see my screen? Thank you, Shirish, for
Yes, sir.
kind.
Yes. Yeah. It's audible. Yeah.
Thank you so much for your kind introduction. And at the very outset, I'd like to thank AIUS, Dr. Namata, Shirish, as well as Dr. Rajesh for giving me this opportunity to share my views on complication and their management. And I have no financial interest in the subject matter of this talk. And this grading, you all of you know, into type 1, 2, and 3. And the major goal of pterygium surgery, as we are discussing throughout this evening, is to have a minimal recurrence, because recurrence is said to be the most important complication of the pterygium surgery, and to have the least possible other complication. And to many people, a cosmetically good result also matters a lot, because again, most important indication for doing pterygium surgery is again cosmesis, and the mainstay of surgery we have already discussed, whether it with adjuvant or without adjuvant. And the primary outcome concerns again is the recurrence of the pterygium and the cosmesis. So I'll be emphasizing more on the prevention, how to prevent recurrence, because as I said earlier, the pterygium surgery is best done first time, and cosmesis is very important from the patient's point of view. All other complications are sort of minor complications and can be, though not minor, if it is mitomycin C related late complication, or if one cuts some muscle during the surgery, or sometimes because of excessive fibrosis, there could be diplopia also. So these are, again, we have discussed, various speakers have discussed the recurrence rates with different methods, and where sclera method is just mentioned to be condemned, it is not used anymore. And these are the 20 years old studies which have compared the outcome of pterygium surgery in primary and recurrent pterygium, and we find the conjunctival autograft has the minimal recurrence rate, as we have already discussed. And this is the largest study by Shirish, not none other than by Shirish, on the complications of pterygium surgery, recently published in IGO. And the common complication, as is highlighted on the left side, as you can see, is subconjunctival hemorrhage, edema, graft loss, graft retraction, and we have discussed all the possible causes also. No, if the graft retraction, if there is too much of tenon with the graft loss, if the suturing is not perfect or the glue application is not good, edema usually happen for 2-3 days. So all those things, and suture granuloma or a tenon cyst, all these can happen, and the long-term complication if one uses a mitomycin C or excessive cautery during the surgery can lead to a corneal melt or a scleral perforation. And of course, if there is a bump formation, you can have a Dellen formation. And these are the possible intraoperative complications. If you are, as Dr. Sujata highlighted, it's very important to avulse the pterygium. Otherwise, many surgeons start from the head side and start dissecting there. Then you may enter a deeper plane. If you avulse it, you never enter a deeper plane, and you get a very smooth surface. And other complications could be if there is a fleshy pterygium for a recurrent pterygium, you may damage the medial rectus muscle. So it is always, maybe I do it mandatorily, even when I teach my resident that one should hook the muscle before you cut the pterygium at the limbus. That is very important because especially in recurrent pterygia, there is a lot of adhesion between the tenon and the medial rectus insertion. And rarely one can end up with a globe perforation during the surgery also. And the graft related problem could be you can have an oversized, undersized, reversal, thick, and orientation may not be proper. Sometimes you may be putting the graft in a reverse orientation. So the most important complication, as I have already highlighted, is the recurrence of the pterygium, and I will highlight how we can prevent the recurrence of the pterygium by adopting various methods during the primary pterygium surgery, and all other these things we could happen because of various reasons. Excessive cautery can lead to corneal scleral necrosis or long-term necrosis can happen if we leave the bare sclera after using mitomycin C. And of course, we have discussed most of this in the paper of Sarish Kumar. So these are the, I mean, this will be the ideal case what will you like to have. This is what we have done is amniotic not an amniotic membrane, conjunctival autograft, free conjunctival autograft. As you can see on first day, the surface is epithelialized, and over a period of 6 months, you get a very good osmosis. Over a period of 2 to 3 months, you can still see little bit of gap in the between the graft and the rest of the pterygium. And also, it is very important because one of the speaker was saying we can tuck in the conjunctival graft. You never tuck in a conjunctival graft. Either we should be pinching it together, or amniotic graft can be tucked in, but never a conjunctival graft. Otherwise, may end up with the inclusion cyst or a conjunctival cyst. So this is another case. Here we have used a amniotic membrane with a glue, and you can see 3 months down the line, though there is a little fibrosis, it is a grade 2 cosmetic result. We will come to the grading of cosmesis later on. So you get a very good cosmesis and very little inflammation after the surgery. And this is another case with the conjunctival autograft, but here there was a little bit of tenon, and you can see edema as well as retraction of the graft on the fourth post-op day. And comparing fibrin glue versus suture, you all know suture leads to much more inflammation, discomfort, more inflammation, and chances of recurrences are much more. So, if possible, one should avoid using the suture and try to use a fibrin glue in these cases. And this is the two eye of the same patient. In one eye, we have done a suturing of the conjunctival autograft. In other eye, we have done a amniotic membrane, and you can see the amount of inflammation because many studies have shown the amount of inflammation post-operatively as well as the duration of inflammation. Of course, the excision of the tenon and abnormal conjunctiva, all those things are uh, I mean, important, but if you do other things in a very good way, then maybe the confounding factors could be a suture or a fibrin glue. And this is you can see a tenon cyst happening at the graft host junction. And you could have a subgraft. This is amniotic membrane graft. You could have a hematoma beneath the graft. Then you have to, maybe you can just puncture the amniotic membrane and just try to press it out. And so these are the different grades of recurrence of the pterygium given by Prabhaswat et al. Way back in 97. This is the normal appearance. grade where is no recurrence. Here there is a mild sort of fibrosis at the pterygium side. This is the true recurrence of the pterygium. And so I will discuss amniotic membrane and graft, and then we will go on to our results. So we have used amniotic membrane in different ways. We have used end-to-end suturing as well as amniotic tuck-in with amniotic fibrin glue, and we have also used a purse string suture, and we found that the results were far better with amniotic membrane and fibrin glue, which are understandable because sutures leads to a lot of inflammation, as well as here we are giving a purse string suture, though that is better than interrupted suture, but still you have to pass suture in a purse string manner all around the uh, all around the amniotic membrane and within the free conjunctival graft. This technique we have already published, and this tuck-in of amniotic membrane underneath the free conjunctival flap we described way back in 2008 in cornea, and we found that the amniotic membrane epithelializes very quickly, which is very important from the point of view of inflammation because amniotic membrane acts as a scaffold, and within 1 week, the whole graft is epithelialized, and over a period of 2 to 3 months, there is hardly any inflammation over the cornea. This is another case where we have done amniotic membrane with fibrin glue. You can see at the end of 3 months, you can hardly recognize any scarring in this case. And this is another case. As we said, we can have complications also during the or after the surgery. Here the tucked in part of the amniotic membrane on first or post op day has come out. Maybe the tuck in was not proper, or the glue sort of polymerized before we could tuck in the graft. So either we can excise it, because if it is lying loose with the blinking movement of the lids, it can lead to more and more of retraction of the graft, or you can tuck it again. So there are two options. Better to tuck it in again and uh, follow up the case. This is one case where there was a graft retraction nasally. So we pulled the graft back. So you can see it has become quite thin and sort of not very good looking graft. And here is a graft with sub graft edema as well as a little bit of hemorrhage, but this resolves over a period of 2 to 3 weeks time, but the chances of recurrences are more in these cases. So coming to the conjunctival autograft versus conjunctival-limbal autograft, this is the uh, this we have already discussed that with suture and without suture. With suture, you get a lot of inflammation as well as graft edema compared to the glue, where you get minimal edema. And these are the results of the same patient as we discussed earlier, where we do glue in one eye and suture in the other eye. And in this we presented in the American Academy of Ophthalmology around 10 years ago. At that time, we found that with glue, this was free conjunctival graft. Our recurrence rate was 4%, and with the suture, it was around 7% recurrence rate. That was a short series of around 20 patients. So now coming to the extended removal of conjunctiva, extended removal of extended removal of pterygium tissue with the extended conjunctival transplant, which was described by Lee Hurst et al. And showed 0% recurrence. This was published in 2008. Then he published a series of more than 1,000 cases and showed that there was almost minimal recurrence. And this paper was published in 2012. And later on in 2009, he also published one paper on recurrent pterygium surgery using pterygium extended removal, followed by extended conjunctival transplant, the recurrence rates, and the cosmosis. Again, he said that with the perfect technique, there was a very few complication and uh, good cosmetic result. This is how he has shown various pterygia with the good cosmetic result. And recently, in 2011, he again published cosmesis as the sort of end result of extended perfect technique or based on a web-based grading system where he graded the cosmoses on the basis of appearance of the eye after the surgery. So this is normal, excellent, good, fair, poor. So you can read this paper. But the main drawback of this technique is we have to remove a very large area of conjunctiva and tenon, and it is he gives continuous suture. It's quite painful, and many patients complain of a lot of discomfort. So we modified this technique, what we call it conjunctival resection and tenon extended removal. In this, what we do is we remove only the conjunctiva which is over the pterygium, and underneath the normal conjunctiva, we remove the tenon almost up to the caruncle and midway between the medial rectus and the superior rectus and midway between the inferior margin of the medial rectus and inferior rectus. So that way you are removing the sort of fibrotic tissue, and these are the few cases where you can see the result. This is on first post-op day where you can see the epithelialized graft, and there's a little bit of staining of the graft. This hemorrhage you see because we have dissected the tenon almost up to this place, so there is a oozing of the blood. But 3 months down the line, you get a very good cosmetic result, and this is with the limbal conjunctival graft. You can see the retapegs here, and over a period of 2 to 3 days, you can see the dividing cell. This pigmentation moves towards the limbus. So you are sure that your graft is surviving, and your limbal stems are intact. Sujata has very beautifully shown how to include the limbus into the conjunctival graft. So this is in a red free. You can see easily the you can see the retapeg, which are the seats of limbal palisades of oak, and the retapeg, which are the seat of limbal stem cell. So this is another patient with the autolimbal transplantation, not free conjunctival-limbal autograft. Again, you can see these stem cells, and this is where you will go up to this. So in one of the paper by the Skirka et al., their complication was that they usually dissect deep into the cornea at the place where they dissect the limbal stem cell, they get a pseudo-pterygium formation. But if you don't dissect deeply, then you are not going to get a, because if you go deep, you create a localized limbal stem cell deficiency, and you get a pseudopenis or a pseudo-pterygium formation in that site. But if you are remaining super conjunctival, you don't get any you don't get crater formation in that area, and you get a very smooth and a good cosmetic result in that case. Here is a one case where you get a Dellen formation. You can see there is a deviation of the line because there is a graft edema. Because of that, there is a drying of the corresponding area. So what we did was lubrication and ointment so that the area remains wet, and this healed with that. And we did also a comparative study of this technique with conjunctival limbal and conjunctival without free conjunctival graft, and we found that at 1 year there was no difference in primary pterygia whether you include limbus into the conjunctival graft or not. So this again we published this paper, and if you want to know the details, you can go on to the cornea journal and see the results. And when we compared our results to the other studies, we found that our results were as good as the other studies. And this is comparing the results with the perfect technique. So we also had almost nil. This was a large series of 40 patients each in both the groups. And these are the few late complications of the mitomycin which has been referred from my From the outside, you can see there is a thinning of the sclera as well as the cornea, and there is a leak. This we treated it by doing a patch graft and covering it with the tenon up to the limbus, because these are the avascular area and heal very slowly. And it is better to bring a pedicle of tenon with the intact blood supply so that healing occurs. If you do a squirrel patch graft without testing many a time, these grafts fail. This is another case referred from outside having a scleral man following a mitomycin C used in the pterygium surgery. This is another case. So, and this was another case which was big for the scleral man
Sir, we have lost you.